And so what I'm going to be talking about today is caring for the sexually active adolescent, and specifically I'm talking about sexually transmitted diseases today, or sexually transmitted infections. I have some objectives. I guess I have to do this. So what I wanted to talk about today, and hope that you take away from this, is, what is that prevalence of STIs in the adolescent population? What are some of the, I hope you all can understand the long-term effects of this sexually transmitted infections in youth. What are those common ones in adolescents? Being able to diagnose and treat them, and know what the screening guidelines are, and what are some prevention strategies. So I have called this STIs. If you look in the CDC, they still use the word sexually transmitted disease. So I have tried to be consistent using sexually transmitted infections. But if you think about sexually transmitted diseases, I mean, there are some long-term disease consequences from sexually transmitted infections. So I'm going to stick with STIs, but just know that there are long-term consequences that can develop into diseases, and I think that's why the CDC continues to call them sexually transmitted diseases. And if you look it up on the CDC website, they will be sexually transmitted diseases. So for some reason, I was not able to incorporate where I got my information on each individual slide. I probably spent an hour trying to insert text box. It would not do it. So I just put the resources up front, knowing that everything I'm saying comes from one of these three resources. So you can see I use the CDC quite a bit. And then there was a pediatric clinics in North America in April of 2017 that was all about adolescent sexuality. There's 13 or 14, 15 articles about adolescent sexuality. So if anybody's interested, I would be willing to talk more about adolescent sexuality, in future discussions. So, but that's a wonderful resource for all of the adolescent sexuality that you would ever want to know about. They talk about sex trafficking. They talk about how to talk to adolescents. It's just a wonderful resource. So what I want to talk about today is about adolescent development, adolescents that, how they get from being sexual creatures, and some of the problems that they have from that. So as you all know, in adolescent development, that's a time where they have increased risk-taking. At the same time, they have a desire for autonomy. And so this results in more likelihood of multiple sex partners. They're less likely to use condoms because of their impulsivity and have unprotected sex. They, just because of their networking, they can develop complex sexual networks. Because young women have an underdeveloped reproductive tract, their columnar epithelium in their cervix is more susceptible to the sexually transmitted infections. And so they're more likely to catch infections than older women are. They're more likely to have older sexual partners. There's also the problems with mental health and substance use, and these students and these patients often have less access to preventive and clinical services, and we'll talk a little bit more about that later. When you look at the adolescent population, half of all sexually transmitted infections are in patients the ages of 15 to 24, and the rates of chlamydia and gonorrhea are highest in women 15 to 24. Again, because of that, because of the columnar epithelium, they can acquire the HPV more common in adolescents, women's, but it does often clear. We'll talk about a little bit more about that later. Again, we talked a little bit on the last slide about risk for STIs. A lot of times, Some of the risks are, that early sex initiation, if they're in detention facilities, if they developed a sexually transmitted infection, if they are young men having sex with men, they are at higher risk for STIs. And then there are some obstacles to health care, and we'll talk a little bit about that later as well. One thing for adolescents that's really hard to overcome is their desire for confidentiality. The minors in all 50 states and Washington, D.C. can consent for their own treatment of sexually transmitted infections. And states are not required to notify the parents, but they can notify the parents. And then when you throw private insurance in there, the insurers are required to send a statement to the insurer to let them know any treatment that has occurred. And so if the student or the patient has not confided in their parents, the parents are going to get the insurance. Now the student or the adolescent patient can pay for it themselves, and they can visit the clinics and pay for it themselves. But if they use private insurance, their parents are going to find out about it. So having these barriers, impulsivity, higher risk for STIs, there's definite consequences for this. And for women, and we'll talk a little bit more about this later, is infertility. Having an STI can facilitate the transmission of HIV. So they're more at risk for getting HIV if they have an STI. And of course, the economic cost is significant, but the personal cost can be devastating. So the more we can help patients prevent STIs, and we'll talk a little bit more about that at the end. So this is from the CDC, and it looks at the rates of chlamydia, and you can see in women ages 15 to 19 and 20 to 24, that is the highest age group for chlamydia. So chlamydia is from the Chlamydia trachomatis. It's the most frequently reported infectious disease in the United States and the second most common one for U.S. adolescents. It's often asymptomatic, but when you do see it, you'll see urethritis, epididymitis in males, cervicitis, proctitis. Women can develop PID, pelvic inflammatory disease, and you will also see conjunctivitis and pneumonia in infants. And it is the leading cause of tubal infertility in women, and it is totally preventable. Now, there are new screening, well, I guess they're not too new, but screening guidelines for chlamydia, and for all sexually active females under age 25, they need, from the USPSTF and the American Academy of Pediatrics, they recommend annual screening. In women, the only recommendations for screening in men is for heterosexual men where there is a high chlamydia presence, and in young men, sex with men, and they recommend more frequent screening for these folks, anywhere from 3 to 6 months. The diagnosis, you can get urine, it's preferred for male. The vaginal swab is preferred for female, but you can get it from urine. And this can be self-collected. So again, one of those barriers for adolescents is, privacy and, the testing, and if they can do a self-collection and the FDA says that that's okay, then you can do that. But you can get it from urine as well for women. And so this is how you treat it. Azithromycin or doxy, a gram of azithromycin once and the doxy for 7 days. So a lot of times you want to actually watch them take the medication, and they'll do that at some of the sexually transmitted clinics. They will watch them take the medication to be sure, especially people who are coming back for repeat testing and treatment. all this information is going to be in the slides, so I'm not going to spend a lot of time on it. I spend a lot of time on the slides, so the slides will be available. So all that information will be available for you. Now the recommendations are that you follow up that in 3 months due to high reinfection rates, but you need to not look at it or test it sooner than a month because there is residual DNA and RNA that will confound the results. All of their sex partners within the last 60 days should be seen and treated. If they have sex partners more than 60 days, they should be treated. And they should avoid intercourse for at least 7 days after the treatment is completed to avoid reinfection. So here's gonorrhea, and you can see that it's a much greater problem. And so young women 15 to 19 is, and the 20 to 24, but then if you look at the men, they're a little bit older, 20, 24, and 25 to 29, but we did see that the teens often have older partners. So I think this is why we see it in the men, older men and younger women. It's Neisseria gonorrhea. It's the second most reported communicable disease. And worldwide, there is resistance to single agents. And so you always see that there's 2 agents recommended for gonorrhea. It affects local mucous membranes and can be disseminated. You will see urethritis, epididymitis, proctitis, conjunctivitis, and it can also be transmitted to the baby during delivery. And you can also see, again, it talks about pharyngitis because of the sexual activity, oral sex in teens. It's not really sex if you just have oral sex, I think is sort of how
Bill Clinton taught us that, didn't he?
What?
Bill Clinton taught us that.
Yeah. So all sexually active women under age 25 should be tested annually, and men having sex with men every 3 to 6 months. The diagnosis, again, cervical, vaginal, urethral swabs, self-collected. I don't know about the self-collection in men for the urethral swab. So if somebody knows that, we can talk about that later. But you can also use the first morning urine for diagnosis. And then this is a treatment, and you can see it's ceftriaxone IM plus oral 1 gram of azithromycin. And again, you'll see this given under supervision at sexually transmitted infection clinics. And then there's alternative treatments. Now, there's a conjunctival treatment as well. You'll see that you follow up for the test of cure in 14 days if using an alternative treatment. So otherwise, and so if you use the ceftriaxone and azithromycin, which is the preferred treatment, you don't have to follow up for 3 months. But if you use one of the alternative treatments, because they aren't as certain that you're going to get it all treated, then you need to follow those up in 14 days. The other one's 3 months. Again, just like chlamydia, 60 days, all the partners, more than after 60 days, they should be treated, and avoid intercourse for the 7 days to avoid reinfection. There are treatment failures, and one way you're going to know this is if the symptoms don't resolve within 3 to 5 days and there's no sexual contact, or if you get a positive when you do your test of cure after adequate treatment. Most importantly, you need to get an accurate history because a lot of times these kids will just go ahead and have sex again. And then you retreat it and test it again. And if it's truly a treatment failure, you need to collect vaginal swabs or urethral swabs and then work with your health department on how to treat this. Syphilis, again, this is much more common in men and mostly sex who have sex with men. Not as common, but we are seeing more syphilis in newborns. In fact, at Altman, we just had a case this past week of a newborn with syphilis. So It's the spirochete Trichomoniasis pallidum, and you can see it in primary, secondary, latent, and tertiary. And as we just saw on that last slide, it's epidemic. Academic? No, that was Freudian. It's epidemic for young men who have sex with men. So you can see there's a incredible increase in the incidence of that. Again, the manifestations depend on the stage. If it's primary, you can see painless ulcers on the genitalia and other mucosal surfaces. Secondary, rash, as well as lesions and adenopathy. And tertiary, many years later, cardiac, neurologic, decades after the initial infection. For screening, young men who have sex with men and pregnant adolescent females. The diagnosis, we usually get either the VDRL or the RPR, but you can often get false positives in pregnancy and autoimmune. So to confirm, you do the FTA or other assays. If you're testing people where the prevalence is low, you're more likely to get false positives. And again, always, if you have questions, you can work with your health department for questions what might be in your community. And again, penicillin is the treatment of choice for syphilis. Follow-up, you need to do it clinically and serologically, 6 and 12 months for primary and secondary, and 6, 12, and 24 months for latent syphilis. Trichomonas, which we don't think is that serious of a disease, and it's kind of perked along at its general kind of low rate. But the reason this is important is because it increases the HIV acquisition 3 times more. So if you have a trichomonas, you're 3 times more likely to get HIV. So, and Black females, for some reason, are at a greater risk for having trichomonas. It can often be asymptomatic, and people can have it for years. But if you do see symptoms, it'll be a yellow-green discharge. You may see vulvar irritation, vaginitis, and cervicitis, and males the same, urethritis, epididymitis, and proctitis. In screening, they recommend screening in sexually active HIV-positive women because if they have the trichomonas and they give it to somebody, then they're more likely to pass the HIV along as well as the trichomonas. So they recommend screening those people. And the AAP, American Academy of Pediatricians, recommend that you consider screening females at high risk. For the diagnosis, we generally do the affirm with a vaginal swab, and you will get both Trich, Gardnerella, and Candida. You can also do urine, and the males, there's another aptema, which I'm not as familiar as I am with the affirm. You treat it with metronidazole. Don't forget, metronidazole has an anti-abuse effect, so you shouldn't use alcohol when you use the metronidazole. And again, I don't do this, but it recommends 3 months retesting. Herpes simplex, this is a hard one because this is chronic and lifelong. You have your HSV 1 and 2, and we used to just think the 1 was more oral and 2 was genital. But we're finding more of the young people with their first genital herpes infection is more likely to be, now is more likely to be the 1. Again, you can get vesicular lesions and ulcerative lesions, oral and genitally. For the new onset, sometimes they'll develop fever, malaise, and adenopathy. It is it's devastating when it's acquired in the neonatal setting. And this is another one. If you have herpes simplex virus 2, it also increases your risk of acquiring HIV, which is considerable concern because this is a chronic and lifelong infection. No screening. The lesions, you get them by cell culture or polymerase. So you can culture the lesions or you can get serology. If you find that you have an HSV2 antibody, that means that you have an anogenital infection. If you get HSV1, that can be acquired in childhood, so you can't really be certain that that is something that's going to manifest genitally. But again, these infections are lifelong. Treatment for your first episode is with acyclovir, valcyclovir, or famciclovir. And then you can do recurrent for episodic or recurrent suppressive, and there's all the medications. Again, once you get this virus, it resides in the nerve system lifelong. So no matter how you treat it, you're never going to get rid of it. You can try suppression if they have more than 6 episodes a year, but you also need to be sure to counsel the patients on the chronicity and asymptomatic shedding. So the asymptomatic shedding makes it difficult to diagnose because they're not shedding continually, even though they have the virus continually. Then there's I think this is the last one I'm going to talk about, is the human papillomavirus. It's the most common STI in the world. And 75 to 80% of sexually active adults will have HPV before age 50. And this was the one I found very scary. 1 in 5 women with only one partner is infected with a high-risk human papillomavirus. So again, a lot of times it's asymptomatic, but it does cause cancer, cervical, anogenital, and oropharyngeal. And also, children can get the respiratory papillomatosis. I think it's from going through the birth canal with somebody who has HPV. And the high-risk HPVs, they're not all bad, but 16, 18, 35, and 41 or 43 are the ones that cause the cancer. There is no HPV screening under age 30 because these folks often get it and then clear it. Again, we're worried about cancer and do the Pap test, so there's no Pap test under age 21. And between ages 21 and 29, you do Pap test every 3 years. The diagnosis is usually clinical. You'll see them. Again, some caveats, there's 10 to 20%, 30% resolution, not indicative of fidelity. That's an important thing because once you have it, you don't know how long it lasts. The treatment does not completely eradicate it, but you don't need to inform future partners. This is the treatment. There's provider-administered treatment, and there's patient-administered treatment that you can recommend for your patients. This just came out yesterday, HIV screening. All women over age 15 and all men over age 15 annually. So between 15 and 65. So prevention, again, HPV vaccination. We want to give all the kids HBV vaccinations. We want to do HPV vaccinations starting 9 through 14. They only have to have 2 shots now. If they wait till they're older, they have to have 3 shots. So I think that's a selling point for some of these adolescents. You won't get poked as much. We want to give them the hepatitis A. You want to give them information about infection, treatment, and transmission of HPV, HIV, and primary care providers should identify risk behaviors and counsel on STIs. They have shown that high intensity, and I was hoping some of our folks would be here that do the counseling because I wanted to know if they do the high intensity behavior counseling for sexually active adolescents. And motivational interviewing are also ways that you can help with prevention, with the goal being risk reduction of risky behaviors. And of course, abstinence, they say to do that. And then this is what condoms can do for you. And for females that want to be more in control, use the female condoms. There is a government program that looks at reducing sexually transmitted diseases. I just wanted people to be aware that the government does say, and it is specifically aimed at younger population. And they actually want to eliminate congenital syphilis as well. Again, this in the red, if we could do this, address underlying problems and cultural conditions, that would hopefully take care of that. And then I just wanted to end with this little study they did at the Minnesota State Fair, where they looked at sexual activity in adolescents and talked to their parents as well. And what I found really interesting in this was that 13% of the kids said they talked to their parents, but when you look at their parents, 90% of them said they talked to their parents about sex. So we're actually not talking about sex as much as we think. So,
or the parents just saying no and the kids ignoring that conversation.
Yeah. So these are my.
Parents are trying.